So let us discuss about intercostal drainage. Intercostal drainage is also called thoracostomy, which evacuates the air or collection in the pleural cavity and re-establishes the negative intrathoracic pressure. So the main intention is to allow the lung to re-expand and restore the physiological ventilation and cardiac function. The main indications are either there should be a pleural collection, like in form of effusion or a hemothorax, or there is a pneumothorax. If you see the guidelines, British thoracic and American thoracic guidelines, in cases of primary spontaneous pneumothorax, if the pneumothorax is small, then you can wait. If the patient is grossly symptomatic, or if the patient is having bilateral pneumothorax, or if the patient is on mechanical ventilator requiring high PEEP and high pressure ventilation, then that is when you have to think of putting an ICD. Otherwise, if the pneumothorax is small and the patient is not very symptomatic, then you can hold on for the ICD. Number two, if the patient is elderly, having some underlying bullous lung disease, and chronic smoker, having secondary spontaneous pneumothorax, then in such case you have to put an ICD according to both the guide. In case of malignant pleural effusion, unless the patient is symptomatic, you need not drain the pleural effusion. Once you put in the ICD, then the following plan should be pigtail catheter or pleurodesis. When a pneumothorax is called as a large pneumothorax, so according to British thoracic guidelines, when the interpleural distance at the level of the hilum is more than or equal to 2 centimeter, then it is called as a large pneumothorax. Okay, so whenever the pneumothorax is large, you have to put in an ICD, or if it is a tension pneumothorax, you have to put in an ICD. Coming on to hemothorax. So when do we consider a hemothorax as a large hemothorax? When the values are less than 300 ml, then you need not put an ICD, you can wait. But if the values are more than 300 ml, then you have to drain the hemothorax. If the hemothorax is draining at 1.5 liters initially, and then continuously it is draining 300 to 400 ml for the next 2 to 4 consecutive hours, then you have to subject the patient for surgery. Coming on to empyema. So, when you take the diagnostic pleural fluid with a suspicion of complicated parapneumonic effusion, you have to first assess the pH. If the pH is less than 7.2, then you have to immediately put in the ICD by using ultrasound guidance. Okay. And if the pH is between 7.2 to 7.4, then you can send a lactic dehydrogenase, where if it is more than 900, then you can think of chances of complicated parapneumonic effusion and put an ICD. But if the pH is more than 7.4, then it indicates a low risk of complicated parapneumonic effusion. Then you can wait for the ICD. If suppose you could not measure the pH, then you can also use a pleural fluid glucose value. If it is less than 3.3 ml, then high probability of CPPE is possible. So you have to put in an ICD. So coming on to the site. As we all know, it is the triangle of safety, where it is bordered by the edge of the latissimus dorsi, the edge of the pectoralis major muscle, and the base of the axilla. Okay, and the line of the insertion should be across the fourth or the fifth intercostal space, across the nipple line, 1 centimeter just anterior to the mid-axillary line, because it reduces the risk of damaging the peripheral nerves of the lateral thoracic wall. Okay, if you need an apical ICD before the apical pneumothorax, then you have to go into the second intercostal space through the mid-clavicular line, but it may be uncomfortable to the patient. Coming on to the various intercostal tube sizes. Okay, intercostal drainage tube is considered a small bore chest tube when the size ranges between 8 to 14 French. It is considered as medium bore when the size is between 16 to 24, and large bore chest tubes range between 28 to 36 French. Okay, and all of them are made of either a PVC or a silicone material. Okay, so small is 8 to 14, medium is 16 to 24, large is 28 to 36. So small, usually the pros of the small catheters are minimally invasive, less painful, and lower infection risk. But it has limited drainage capacity and potential clogging possibility, right? So it is mainly used for pneumothorax or a very minimal pleural effusion. Whereas large bore is effective for large volumes of fluid and air, and it also drains hemothorax and empyema efficiently, right? But it can be more painful, higher risk of infection possibility is there. And the third type, the pigtail catheter, which may not be used in the emergency situations, but maybe once you drain the malignant pleural effusion, you make the patient less symptomatic. If you feel there is a recurrent collection, then you can put in an indwelling pigtail catheter, which is minimally invasive, less chances of infection. But chance of pigtail getting occluded, getting coiled, getting knotted is a possibility. Now we can see what are the methods you can put in an ICD. There are 3 methods. One is dissector, which we commonly use during the emergency situations. Next is the Seldinger technique, which is used with the pigtail catheters. And the Trocar technique, again we use with the emergency situations. So dissector, you select the appropriate fourth or fifth intercostal space. You make 1 to 2 centimeter incision parallel to the rib space, and you use a tonsil clamp to bluntly dissect the subcutaneous tissue, where you are dissecting the muscular layers of the intercostal space, that is external intercostal muscle, internal intercostal muscle, innermost intercostal muscle, and also the transthoracic fascia and the parietal pleural space. So once you enter the pleural cavity, there will be a giveaway feeling, and this dissection should happen through the upper border of the lower lip, okay, so that you don't affect the neurovascular band. Okay, when attempting to enter the fifth intercostal space, you should not go perpendicular to the chest wall. You should always go in the posterior apical direction. Okay, when you dissect perpendicular to the chest wall into the fifth intercostal space, it can make the tube directly head into the oblique fissure of the lung, and the tube can be entrapped by the subsequent expanded lung, rendering the tube ineffective. Okay, once you spread the pleural space, a finger can be used to confirm the entry into the pleural space. Position the tube in the posterior apical direction, and the tube should be fully inserted to ensure the most proximal hole is within the pleural space. Once you put in the tube, you should connect it to an underwater seal drainage. This underwater seal drainage, it restores the proper air pressure on the lungs and helps to re-inflate the collapsed lung, and also removes the blood and the other fluids via gravity. Okay, it also acts as a one-way valve so that whatever you remove does not re-enter into the thoracic cavity. Okay, so there are three types of underwater seal drainage, that is one chamber, two chamber, and three chamber. So let us discuss about the one chamber. So it just collects and contains the fluid from the pleural space. It seals the air leaks using a water barrier, that is the underwater seal. So when you see a rigid tube is immersed into the water, usually at 2 centimeter. So a rigid tube is inserted 2 centimeter below the surface of the saline solution in the bottle, and the other end is connected to the thoracic drainage tube placed in the pleural cavity. There is a one-way decompression valve vent which allows the air to escape and prevents the pressure to build up. Okay, so you can see that one end is connected to the ICD, and the second end of the rigid tube is immersed into the water at a level of 2 centimeter. So this creates a negative pressure. When pleural pressure is positive, that is during exhalation, the air is forced out of the chest and travels through the rigid straw and bubbles into the water. And excess air is vented out into the atmosphere, where there is a vent tube, and it should be kept open in a single chamber tube. Okay, when the pleural pressure is negative, that is during inhalation, some of the water moves into the rigid tube, but it cannot enter back into the space because a negative pressure is already created at 2 centimeter depth, right? So this water seal prevents the air re-entry and acts as a one-way valve. Okay. So what are the limitations of one chamber? It is ineffective if the rigid straw is above the water level. Obviously, the system fails. And if there is a large amount of fluid draining into the bottle, then the fluid level raises, making it harder for the air to escape. So this air can get trapped in the chest, preventing full lung re-expansion. This tube works better for pneumothorax, but it is not ideal for large fluid drainage. Okay. And sometimes when the bottle is kept higher than the patient's chest, then there could be some backflow that could happen coming onto two chamber. So large quantities of liquid are drained from the pleural cavity, then we can use a two chamber, where one chamber is exclusively for the drainage and the second bottle creates the negative pressure chamber. Okay, so you can see that the first chamber only collects the patient's drain, and the second chamber there is a rigid straw which is immersed into the liquid at the level of 2 centimeter, creating the negative pressure, and there is an air vent which pushes out the excess air. So coming on to three bottle system. A third bottle is added when the negative pressure is required to facilitate lung expansion or accelerate the air movement. So it is connected via a vent to the water seal chamber. So the rigid straw in the suction bottle determines the level of the applied negative pressure. The negative pressure is equal to the depth of the immersion of the rigid straw in the liquid surface of the bottle. But excessive suction can increase air leaks by pulling air through an opening in the lung that might otherwise close naturally, creating a fistula. So you can see that there is a drainage chamber which drains the collection from the patient, and there is an underwater seal which maintains the negative pressure for the pleura, where the rigid straw is immersed at a depth of 2 centimeter. And there is a third chamber where you can see a rigid straw is immersed into the water, and this immersion level determines the negative suction, okay, not the wall suction that is being connected to the third chamber. So if large air leak is detected, or if there is subcutaneous emphysema, or there is an expanding pneumothorax despite of the ICD connected to a two chamber, an additional suction of minus 10 centimeter of water should be applied. Okay, and in some of the systems there is an inbuilt air leak meter which is present, which detects the degree of the air leak from 1 to 7. So whenever the air leak is more than 3, then it is considered to be a significant air leak where you have to connect the patient to the negative suction. So what decides the suction pressure? So the amount of the suction applied is equal to the depth of the rigid straw in the third chamber suction control bottle. So if the straw is immersed at 10 centimeter into the water, then the suction pressure is minus 10 centimeter. If the straw is immersed at 20 centimeter into the water, then the suction pressure is minus 20 centimeters of water. Just by increasing the wall suction does not increase the negative pressure. Okay, you don't, but only by adjusting the depth of the water column, you can adjust the suction pressure. So suction can be of two types. One is wet suction and dry suction. Wet suction, wherein a third chamber there is a rigid straw immersed into the water, and the depth of the immersion decides the suction pressure. There is also another type of suction called dry suction, wherein a dry suction regulator is there which controls the suction. So you can see that this is one of the wet suction, where the initial first two parts, first three or four columns are for the drainage of the patient collection. Okay, and the second is the underwater seal, where a constantly 2 centimeter at 2 centimeter depth the underwater seal is maintained. And the third chamber, which is the suction control chamber, where the depth of the immersion decides the suction pressure, not the wall connection. Coming on to the dry suction, you can see this is the collection chamber, this is the water immersion chamber, and third, there is no suction control chamber, but there is a suction control regulator, where the suction control can be set between minus 10, minus 15, minus 20, minus 30 based on the patient's clinical condition, and the dial can be adjusted. Whereas in wet suction control, you have to immerse the rigid tube in the third chamber according to particular length. For example, if you are immersing at 10 centimeter, then the suction is at minus 10. If you are immersing at 20 centimeter of water, then it is at 20, minus 20. What advantages and disadvantages of the wet and dry suction control? So wet suction, where you can visibly see the bubbling in the suction control chamber, and you can detect the air leak more earlier than the dry suction. But dry suction control is very easy to set up and adjust. You may not see any fluid evaporation, but the only disadvantage is that you cannot see the bubble. So you have to connect it to a bubble leak monitor to detect the air leak. When you compare all the three, one chamber, two chamber, three chamber seems to be the more efficient method of draining the ICD, especially when the patient is having expanding pneumothorax or subcutaneous emphysema or with more air leaks, right? But one chamber can be efficiently used for simple pneumothoraxes or tension pneumothorax. Another underwater seal is disconnected from the wall section and vented to the atmosphere. So if suppose the other three system fails, then this can take over for the negative suction pressure. So when should we remove the ICD? So in case of pneumothorax, once you see the lung fully expanded in the chest x-ray, you try clamping the ICD for 6 hours and then repeat the chest x-ray. If there is no expansion of the pneumothorax, then you can remove the ICD. If it is a pleural effusion or a collection, at least it should be, the collection should be less than 2 ml per kg per day, or at least less than 200 to 300 ml per day. That is when you can remove the ICD in cases of pleural collection. What are the complications of the ICD? There could be tube malposition, then you have to reposition the tube. There could be a blocked tube where you can try milking or replacing the tube. There could be re-expansion pulmonary edema, where you may have to support the patient with oxygen and mechanical ventilation. There could be subcutaneous emphysema, where you may have to connect it to the negative suction or use a 3-chamber. There could be nerve injuries and cardiac injuries, which should be repaired surgically. And there could be pulmonary artery injury. Emergency surgery is warranted if that happens. Okay. Esophageal perforation is also a possibility, but immediate surgical intervention is required. And the most common complication is bronchopleural fistula, where you may have to do a prolonged drainage and endoscopic or surgical repair if it persists beyond 5 to 7 days. Okay. Chylothorax can happen where surgical intervention is required, and infectious complications are very common, where you may have to take care of the ICD site and treat it with appropriate antibiotics. Okay. When it comes to bronchopleural fistula, What are the ventilatory management of bronchopleural fistula? And this was asked as a Viva question. You have to reduce the mean airway pressure. Okay, reduce the number of the positive pressure beds using the lowest number of mechanical beds that permits the acceptable alveolar ventilation. Okay, try to wean the patient completely if possible. Try to put the patient on SAMV or a pressure support mode rather than a control mode. Okay, and consider use of permissive hypercapnia if the pH is maintained, and reduce the tidal volume, reduce the inspiratory time so that the mean airway pressure can come down, keep the inspiration to expiration ratio at 0.33, use high inspiratory flow and avoid inflation hold. Okay, inverse ratio ventilation. Minimize the PEEP. Use least amount of chest tube suction that maintains the lung inflation. If suppose spontaneous breathing distorts the picture, then you sedate and ventilate the patient. Okay. Avoid position differences that could exacerbate the leak, and treat bronchospasm or any expiratory flow limitation. Okay. So this completes our ICD lecture.